everybody. Thank you so much for coming. My name is Eve Tupper. I'm an associate professor in psychology and neuroscience and here in global health. I also am excited to direct the newly launched Duke Center for Global Mental Health, which we hope to be a hub for Duke and our partners who are interested in global mental health. So that QR code will take you to our webpage with contact information. So we would love to connect with anyone who is interested. We really appreciate your attendance at You've Got a Friend in Me, peer-led interventions to improve adolescent mental health. And I am very excited about the panelists that we have. A couple of logistics just to let everyone in the room and online know that this is being recorded and will be posted publicly. So all of your excellent questions will be documented for others to learn about. And also the people who are joining by Zoom, we can take your questions in the question and answers tab online, and we'll get to as many of those during the Q&A as we can. And then those of you in the room will have plenty of opportunity to just raise your hand and ask from here. So I want to just introduce this topic briefly before we hear from the panelists that we have here today. Adolescent mental health is really a global crisis right now, both in low and middle income countries, which we often focus on in global health, but also in high income countries as well. 10 to 20% of children and adolescents worldwide have a mental health disorder. 45,800 adolescents die from suicide each year. Half of all of the mental health challenges that we see throughout a lifetime have an onset before the age of 14, but often are undiagnosed. In low and middle income countries, there's less than 0.1 psychiatrist for every 100,000 young people, and in high income countries, only 1.1. We will focus on work that is in low and middle income countries today. But I did want to just remind us that we see mental health disparities here in the US and in North Carolina. 1 in 6 youth in the United States will experience a mental health disorder. More than half of the counties in the United States don't have a single psychiatrist. North Carolina ranks 45th out of 50 for pediatric mental health care. And in 2016, almost 3/4 of children with a mental health disorder documented in North Carolina did not receive any treatment. We have enormous gaps, enormous unmet need. And within this, of course, is disparities between people who have more access and others who do not. Closing this treatment gap is, of course, an enormous job that is going to take a long time to tackle. One of the essential pieces to closing the treatment gap is creative solutions to deliver and sustain the programs at scale. One of the most effective strategies in global mental health and in implementation science and global health more broadly is task sharing. Many of you have probably heard about this across fields, but overall, this is training non-specialists to deliver care. One specific type of task sharing that we'll focus on today is peer-led delivery. Peer-led interventions are delivered by trained non-specialist peers that have some type of shared experience. You'll see in the examples we'll talk about today that lived experience and shared experience can mean very different things. So it might be sharing the same age group, being in the same age group in a specific context, sharing the same gender identity, or experiencing the same mental health or physical health problems of the participants in the intervention. So there's a wide range, but if you think about that, the strengths of this are multi-layered. So it's a task sharing model. So it's a creative way to fill the human resource gap. But these peers, and you can imagine this as you hear the descriptions from our panelists, have the ability to show an understanding and an empathy for participants in these programs that really would be impossible for any other non-specialist or maybe especially even other specialists to offer. So with that, I am absolutely thrilled to introduce our three panelists today who have been had personal experience implementing peer-led interventions. I am going to give them just the briefest of introductions, but DGHI has posted their more complete bios on the event site that are incredibly impressive. So please do go to that to read more about them. We will first hear from Dr. Primrose Naimayaro, who is a mental health researcher based in Zimbabwe. So we appreciate two of our panelists joining late in their evening. She's currently the program manager for African Youth in Mind, which is a research study adapting an intervention suitable for youth aged 15 to 24 with depression in both Ghana and Zimbabwe. Then we'll hear from Dr. Dorothy Dow, who's an associate professor in pediatrics and global health here at Duke, visiting us from Tanzania, where she lives and is based. So we are very fortunate to have her here in person. And Dr. Dow's research focuses on the prevention and treatment of HIV in pediatric populations. And the work she'll discuss today is at the intersection of HIV and mental health. And then finally, we'll hear from Dr. Florence Chikuga, who is a psychiatrist and the head of alcohol and drug abuse rehabilitation services at the Moi Teaching and Referral Hospital in Eldoret, Kenya. And her expertise includes treatment and prevention of substance use disorders, and her research focuses on lay provider delivery models in particular. So we will start today with Dr. Naimayaro. And each panelist will give us just a few minutes about their work, and then we'll follow by some questions from me because I get to ask the first ones as the moderator, but then leave some time for questions from you all in the room. Rose, I will pass it over to you, and you should be able to share your slides now and be heard in the room.
All right, thank you. I hope you can see the slides.
Yeah, that's great.
Okay, great. Well, thank you for the introduction and also for the opportunity to come and speak about some of my work that I'm working on in Zimbabwe. Okay, so I will start by describing some work that is currently ongoing in Ghana and Zimbabwe, as you mentioned when you were reading the bio. So I am the program manager for the African Youth in Mind program. And African Youth in Mind is a multidisciplinary group of researchers from Zimbabwe, Ghana, and United Kingdom, working with youth to adapt and evaluate an intervention suitable for youth in Ghana and Zimbabwe, age 15 to 24 with depression. So in Zimbabwe, this is led by Professor Dixon Chibanda, in Ghana, Dr. Ben Werbong, and in United Kingdom, Professor Melanie Abbas. And since this is still an ongoing program in putting together this intervention, I've just highlighted here some of the active ingredients that are going to form the components of the intervention when it's eventually finalized. So the three ingredients are psychoeducation, behavioral activation, and then problem-solving therapy. And then the next intervention I want to highlight is the Friendship Bench, which originated from Zimbabwe, also founded by Professor Dixon Chibanda. And I have put here some of the social media handles and also the website for you to go and get more information about it. But Friendship Bench offers a psychological intervention called problem-solving therapy, which is based on cognitive behavioral therapy. And it uses a task-shifting approach, which you mentioned in the introductory slides, with lay community health workers in primary care clinics, as well as young people who we call friendship bench buddies that I'll describe in detail just now. And there is a physical bench like the one being shown on the slide that is available in different primary care clinics that people can go to and speak to someone. Usually the community health workers, grandmothers, so older women who work in city health clinics who have been trained on friendship bench. Or it can also be with a young person who's a friendship bench buddy. There's also an online version of Friendship Bench, so it can also be accessed digitally. And the intervention is provided over a period of 6 weeks. So here I'll just give a brief overview of the different steps for problem-solving therapy. So the first step is problem identification and definition. And at the bottom there, I have what we call it in one of the local Zimbabwe languages. So on each of the steps, you'll see there. So in the first session, when someone comes to Friendship Bench and they've been assessed, they've been screened, and they've been found to have symptoms of depression, the counselor they're with will help them to identify the problem and define the problem that they are presenting with. And then in the second step, they will brainstorm solutions and decide on one solution to go home and try out. Then in the next step, they will create and implement a SMART action plan to ensure that there's a solid plan in place for when they leave the session and they go home and try to implement the plan. When this has been done, then the session ends, and the subsequent sessions that come after that are to review the progress, to discuss, if there were any barriers that they faced in implementing the solution, if they think they should implement a different solution, etc., until they have completed their sessions. And then the other component that I think is important to highlight today, since we're talking about peer-led interventions, is the youth version of Friendship Bench. So it's peer-led by young people, and training is done by Friendship Bench trainers who are also their supervisors. And the training is done over a period of 8 days, and it covers screening for depression, using problem-solving therapy steps, referral, and also how to collect data. So the trained buddies receive ongoing support and clinical supervision throughout their 10-month internship. So these buddies are usually university students who are enrolled in programs such as psychology or social work. And as part of their undergraduate degree programs, they're required to go for a placement of 1 year. So some opt to come to the Friendship Bench, and that's where they're then trained. So they are usually, about 22, 23 years, 21, 22, 23 years old, most of them. And group supervision for the buddies is done twice a week for an hour. And the content includes case presentation and review, training on additional skills and other challenging topics that they may come across. And also there's one-on-one supervision that is provided when needed. And then fidelity is assessed by the supervisors through listening to the audio recordings, if they did the session in person, or using online transcripts if they provided the intervention online. And the fidelity is checked using a standardized checklist. And yeah, that's all I have to share for now. Thank you.
Thank you so much. I have so many questions for you, but for now we're going to pass it to Dr. Dow to describe the work.
Thanks, Eve, and thanks to the panelists. I think this is super exciting to hear everyone's work. I want to just say thank you to a third-year student who works with us in Tanzania. She's a Duke Singapore student, and this is really her title. So thanks to Dana for being so creative and letting us use this. Let's see if there we go. So you might wonder, my training is in pediatric infectious diseases. Why am I sitting on a panel about mental health? And so I just wanted to explain a little bit. When I went to Tanzania in 2011, the adolescents were really doing poorly. And antiretroviral therapy is free. And these are youth who sort of survived childhood, right? The stats without medication is that half of infants who are perennially infected die by the age of 2. So I was seeing the survivors now dying when medicine is free and available, and I didn't really understand why. And so we applied for a Duke Center for AIDS Research Development grants, and were able to sort of assess mental health as a component of what was driving these poor outcomes. And we did find that indeed mental health difficulties were very prevalent, 25% to 50%, depending on the clinic. And they were really highly associated with poor adherence and poor outcomes. And so this is just one of the many interviews and quotes that I think really summarize kind of what I think was going on. And this young woman says, the only thing I would like to change about myself is the disease that I have. If I could, I want to be HIV negative, so I could go on and get married, have a baby, and be happy. And for her, HIV meant these things were not possible. And if these things aren't possible, why would you take your medicine? And so we sort of set out to try to address this depression and this sort of loss of hope. There was no, as Eve mentioned, the provider gap is tremendous. There was no mental health department. There wasn't a psychiatrist or psychologist at the time, but we really felt we couldn't uncover this and sort of do nothing. And so I think the main point of this slide is just, I think the dogma is really now accepted that if we can improve mental health, we can improve adherence and virologic outcomes. And so that's my role here on the panel, is to talk about Sautia Vijana, or the voice of youth. Because there was such a gap, I reached out to my dear colleague, Karen O'Donnell, who's a psychologist who had been working in Tanzania with youth who had experienced a lot of trauma and grief. And so with Karen and with youth who live with HIV, who were really part of the original study and really advocates for wanting to make change, they helped us develop this intervention. It's manualized and protocolized, and our hypothesized mechanism of change is again, if we can improve these sort of mediating factors, mental health and other things that go with it, how you cope, if you're having a lot of internal stigma, how social support can help you kind of get through some of the dark days, that maybe we could improve adherence and HIV outcomes. And so our protocol is for youth who are, or adolescents and youth who are 10 to 24, but we tend to focus on the 15 to 24-year-old age group. To be involved in this study, they needed to know their diagnosis, be able to really understand that they live with HIV, to be prescribed medicine, and did not have to endorse mental health difficulties. This was really thought to be both preventative and potentially a treatment. And so sessions are held on Saturdays. Typically, they're usually an hour and a half to 2 hours. There's 10 group sessions. 2 of them, we have caregivers join with the youth, and there's 2 individual sessions. And so this is just a little bit about what the intervention looks like. There's 3 different evidence-based psychotherapies, components of those that we utilize. So in sessions 1 through 3, we talk a lot about cognitive behavioral therapy and how your thoughts really affect your feelings and behaviors. in the 4, 5, and 6 sessions. This I think is very unique to this intervention and was really driven by youth and the data, but we do a trauma narrative. So they tell their peer youth leader one-on-one when they found out that they live with HIV, which is often not when they were first diagnosed, what was going on before, during, after, and now. And that is really hard and really traumatic. And it can also be triggering for the peer youth leader who has that lived experience. So this is, I would say, maybe the most pivotal part of the intervention, but also the trickiest. But we think it's really important. They then share their story in the group if they're willing, and that helps normalize. A lot of the youth sort of say, I had no idea. I thought I was totally alone, and now I know, I'm not. And so I think that's really important. And then we ask if they're willing to share with their caregiver. And that sharing is not a new disclosure, but it's to give the caregiver a window into how life has been for them, to try to open up communication. Because we know adolescents are kind of difficult sometimes to communicate with. So it's to kind of bridge empathy and sort of understanding. And then we talk about circles of support, kind of interpersonal psychotherapy. We specifically talk a lot about stigma, which is represented by a snake that might sort of strangle you, or people might be throwing snakes at you for external stigma, and how you can cope and hopefully reduce this. We talk about disclosure, and then values, what they value, how they can move on positively. And so we had some really great success with this. Youth loved it. They wanted more. They attended and they were really enthusiastic. We were able to show non-significant, but reduction in mental health challenges for those who received the intervention, as well as improved adherence and 10% improved virologic suppression. And so that was enough of sort of preliminary data to help us get an R1 to scale this. So now we're in 4 different regions of the country. We're powered to see, is this effective? And our primary outcome is on virologic suppression. It's not on mental health. That's a secondary outcome. So we look at, how does this work? Who does it work for? What are the implementation barriers and facilitators? And I wanted to also briefly mention an exciting study that I co-chair with Jerry Donnenberg. And so this is through the Impact Network. It's a really novel thing that Impact is doing. They haven't evaluated mental health, especially in a low and middle income setting with youth. So this is also peer-led, group-based intervention that's manualized and protocolized. It was started in Rwanda. It's called Bright Futures. We're in 4 countries, one of which is Zimbabwe. You can see Botswana, South Africa, and Malawi. And the scientific question here is, can this peer-based group-led or peer-led group-based intervention improve mental health outcomes? So here it is, mental distress. And can we make that better? And then secondarily, does that indeed improve adherence and HIV outcomes? So the content is somewhat similar, but also pretty different to SYV. It's 6 sessions, it's group-based. There are 2 caregiver sessions, but the caregivers are separate entirely from the youth. And then just to say some of the lessons that we learned, and I think you're hearing this, supervision and training is critical. Sometimes we're asked, is there a high turnover? What happens with the peer youth leaders? In our experience, they're really dedicated and they really are there for altruistic reasons and wanting to help their peers survive. Referral for those who have encounters where someone's beyond sort of their scope of training is really critical. And so having those pathways. And then the other challenge that we face is, if you're really a youth peer leader, you age out of that. You can't stay a peer leader forever. And so I look forward to hearing from my colleagues all that they have going on and to share sort of lessons learned. So thank you. These are our websites if you're interested to learn more about the studies.
Thank you so much, Dorothy. We're gonna transition now to Dr. Jaguka, who is with us from Kenya. And Dr. Florence, I will advance your slides for you if you just let me know when. Oh, you're muted, Florence.
Yeah, thank you. Thank you, Caitlin. I'll let you know when it's time to advance the slides. I'll be talking about the peer-led youth mental health work that we do here in Eldoret, Kenya. Moi Teaching and Referral Hospital is a tertiary level facility. In Kenya, actually, they're the second largest in the country. Next slide. Just like has been said by the previous presenters, so many youth have mental health problems. We can see that in Kenya, a study found that 44% of youth had experienced a mental health issue in the past year. Yet services that support youth mental health are very scarce. When I think about the entire Western Kenya, I'd say we have only about 4 facilities that are dedicated for youth mental health. And also we can see that the number of mental health care workers are very few, with a ratio of 1 to 400,000 and a very high treatment gap. So peer providers could close that treatment gap. And a lot of the work that we've been doing tries to see whether it's feasible to have peer providers implement interventions for young people. Next slide. Since about 2021, I've been involved in a number of research projects together with Eve and other collaborators from here and also North America. The first one was funded by Fogarty, NIH, and the goal of this one was to try and see whether it was feasible to have peers implement a substance use brief intervention for youth at a clinic. It's largely a HIV clinic within the hospital, but there's a few youth who come in who are not necessarily HIV positive. And we focused on youth who are aged 15 to 24 years. So what we did was to train the peers over a 5-day period, and then the ones who achieved competency went ahead to implement the intervention to about 100 youth. So thereafter, we sought views of the youth, the peers, and the clinic leaders on the intervention. Next slide. So what we found that the youth were comfortable interacting with the peers. They did like talking to the peers. They felt that the peers were relatable, they could understand them. So the interaction overall was reported positively. The peers also felt that the intervention was easy to deliver. This was actually, it's a single session motivational interviewing type of intervention offered of about 15 to 20 minutes. And the peers felt that that was something that they could do easily. And also the clinic leaders felt that that intervention aligned well with the goals and the needs of the clinic, and that going forward, it was possible to integrate it into clinic processes. So overall, we had very positive feedback from this initial pilots. Next slide, please. So that work has already been published. You'll see the reference at the end. Sorry. So right after that, we got funding again from Indiana University to conduct a pilot RCT, again following up from the previous project. So the goal of the pilot RCT was to obtain data on whether it was feasible to conduct a full-scale randomized controlled trial, but also gain some data on preliminary efficacy and additional data on acceptability, still on the substance use screening and brief intervention that's peer-led. So data collection, again, is complete for this next pilot, and analysis is going on. So hopefully we'll have the findings out for that. So the goal is to ultimately move to a full-scale trial. It's exciting to see that Dorothy was able to move to an R1. Dorothy, that's where we are aiming. So hopefully next time we have this discussion, we'll be talking about ongoing R1 work if it's successful. Next slide, please. So there's that, the first two sets of studies that are looking at peer-led substance use interventions. And then this other one called Husisha Project. Husisha is Swahili for bringing together. So this one, we trained peers again to implement a 5-session problem-solving therapy for youth with internalizing disorders. So depression, anxiety, stress, those kinds of disorders. And the peers have been able to successfully deliver the intervention, follow the youth across the multiple sessions, and data collection is almost complete. So we are looking at preliminary effectiveness, but then we are also obtaining qualitative perceptions of the peers, the youth, and the clinic leaders as well on the intervention. So again, this is ongoing, not yet complete. And once the results are out, we'll be able to publish them and share. But overall, we see that, you know, your peers can be trained to implement 5-session mental health intervention for young people, and that they're able to successfully implement it. So we can see them implementing very simple single-session interventions, but also, you know, they can go ahead and implement slightly more complex interventions. And in this case, for all the studies I've talked about, we've used the term peer to mean near age mates or age mates rather than having, you know, lived mental health experience or lived substance use experience. Peer in this sense relates to age. Next slide, please. Yeah, so that's kind of like the research work that we've done, that's ongoing. And then at the youth clinic, our adolescent clinic at the hospital where I work, peers are very much a part of the system there, and they are peers in the sense that they have HIV lived experience. As I said earlier, that clinic largely takes care of youth living with HIV, but then over time we've had other youth come in for general services like listening to stuff about life skills training, coming to dance salsa, coming to play table tennis, and so on and so forth. So it's becoming like a hub where youth, both living with HIV and without, are showing up. So the peers in that facility are involved in educating their fellow youth on, you know, substance use harms, offering general counseling and support, you know, with the issues that young people face, like bullying, like relationships with friends and family, you know. And then also importantly, they offer HIV adherence counseling. So, and they are fully supported by the youth clinic. What I mean is that they are fully stationed at the clinic and receive a stipend or salary at the end of the month for it. So they are recognized as a very important part of the HIV stroke mental health care offered at the clinic. So concerning the kind of training that the peers get, it's not yet structured. From time to time, they do these 5-day trainings, and their capacity is built on things like basic counseling skills, or issues to do with HIV medication, how to monitor adherence, a bit of information on sexual and reproductive health. So very you know, training that's not quite structured, but that happens from time to time. And the hope is that over time we can develop a, you know, a curriculum just to make sure that, you know, training is offered at entry into the clinic, and then there's refresher trainings over time. just to make things more structured. But this just shows that peers are a very important part of, the youth clinic at MTRH. Next slide, please. So what have we learned through the research work and through seeing the peers involved in offering care? So what we've learned from the studies that I've done, that peers need adequate training. So we learned early on that giving lectures alone is not enough. It's fine to give lectures, but limit those and do lots of role plays, lots of discussions, and that kind of thing. That really helps with knowledge acquisition, but that they really do need a lot of training in the beginning. We also learned that specific counseling skills can be tough for them to learn, like reflection, summarizing, and they would need a lot of training, a lot of supervision for them to grasp that skill. Also, they can have challenges with handling complex situations. And overall, what I feel about this is that it's important for peers to implement the sort of simpler interventions for youth with mild to moderate mental health symptoms. And then as things get more complex, severe, it's important to have very strong referral mechanisms so that the peers are able to refer. So you sort of need like stepped care with peers, handling the, what I mean is the screening is done. And then for low risk, youth, they could be handled by the peers. But then when they're moving towards, higher severity, moderate, and severe, then those are seen by the mental health specialists. We also learned that peers feel good about implementing mental health interventions. They would give feedback like, I felt like I was a mini counselor, it was rewarding, that kind of thing. So they feel really good about being able to help and support their fellow youth. I think I've talked about supervision being needed, and on-job training, just making sure that other than the initial training, there's continuous support and supervision. And I think I also talked about the good referral systems are quite important so that the youth don't feel overburdened, but also just to make sure that we are not causing harm by having lay providers deliver to handle extremely complex cases. Okay, next slide. So a couple of references. Reference 3 relates to the initial work I had talked about from the Fogarty project, piloting the substance use intervention. Next slide. Thank you so much. That's the end.
Thank you so much, Florence. I am really inspired by all of the work that you all are doing. And I think we probably all noticed some of the common lessons learned. One of them that stands out in all of your work and the work that I've done with Florence and others in Kenya is the need for training and supervision. Every one of you talked about how important that is. One of the challenges with that is that our next task after this is to scale up at a much larger scale. I do not have an answer to this question, but I'm really fascinated to hear what all of you think about what are the possible paths to scaling up to even larger numbers once we have the strong evidence that we need. What are the creative ways that we could reach much larger numbers of people, but without sacrificing the quality, the fidelity, the intensive training methods and supervision that we know, especially peers might need. There's someone who would like to go first.
I mean, I can offer something quickly, but I'm very curious to hear from Rose and Florence about this. When we went from 1 center to 4, someone warned me that we were gonna go to 5, and they said, "You're crazy. That's no, like 4 is a lot already." And it is, and it's because you're also working with different centers, institutions, like there's a lot going on. I don't have the answer here either, Eve, but what I will say is, what the youth leader, so first of all, the original youth leaders aged out, and they were very upset and felt like other people were taking over their job. But we needed them. They helped create the intervention. The intervention worked because of them. So they became sort of the expert group leaders, and they helped us train the next cadre. And then supervise, so it just became more layers, which is complicated, but also has worked quite well. So this sort of idea of a train the trainer model. I think the easy answer is, oh, you can just, record it and play it as a video or go online and do it virtually, but I just don't think it's the same. I think the magic happens in person, in a group with your peers and this safe space. And I don't think you can create that virtually. It is kind of my thought on this, but it sounds like maybe Primrose has some experience, and I'm really curious how that goes. How do you create a safe space in a virtual world? Because I think that's the answer for scaling. I just don't know if it works.
Yeah. So I think to answer the question about scaling up, I think it's important to integrate it into an already existing system. In our case, it's primary care clinics, and the city health department is a big partner, and they've taken up the intervention to have it provided in the different clinics. So that certainly helps with scaling up. And then for the supervision, I think, yeah, it's important to invest in supervision, especially with peer counselors, because you need to be able to provide them with support. Because if they're peers, because they also, maybe have depression, you're supposed to be able to also, provide support for them. And how it's done for the digital part of the intervention. So I mentioned the transcripts are used by the supervisor. So they will read the transcripts and ensure that the intervention is being done well as part of the supervision. So I don't think there's an easy way out of it, even if you scale up. I think it's just something that needs to be invested in and taken up. Yeah. Thanks.
Thanks, Primrose. Florence, do you have thoughts on the scale up and sustainability of these interventions?
Well, and what I've seen over time with the mental health interventions we've tried to scale up is that you have to work with people. It's a slow journey. It's painfully slow, but you have to make sure everyone is on board. So thinking about a broad range of stakeholders, it's the county government, it's potentially the national government, it's people with lived experience, it's all these government departments that handle health-related issues. It's community-based organizations and NGOs. It's sort of like bringing everyone to the table, talking about your research findings, and then talking about how you plan to scale it up. You have to have buy-in, and you have to, the government needs to want to implement it. So say, for example, you want to integrate it in healthcare. I can do that by myself. I could never do that as a researcher. I need for the county minister of health to make it policy and to say, yes, it's fine for us to train or employ peers within the healthcare facilities to do this. So I've found over time that you can't work as an island, and And also thinking about collaboration right from the beginning. So when you're designing your research, when that initial idea is there, like when thinking about the R1 right now, I'm already thinking, okay, so who should I talk to? Policymakers in the substance use space, just roping people in right from the beginning and making sure that you're moving along with them. Yeah. So I found that quite useful for making sure things are scaled up and sustainable. Because once the funding is over, then what happens? So you need the government to have taken it up.
Thanks, Florence. That's a really good point, and I think one of the hardest things that we do, and maybe something that we don't always train researchers and students to do in the academic environment, which is really a big steep learning curve for many of us. I would love to go back to you, Primrose, about the digital scale up strategies. We've heard Dorothy's sort of hesitations about the creating a safe space. I would add to that, Florence, you could comment on this too, the idea of being in the same virtual space at the same time versus asynchronous interventions people can do on their own time. I was wondering if you could share some brief thoughts from your experience on that.
Thank you. Yeah, so I think the digital intervention or component of the intervention works well for people who cannot come to the clinic. Because like I mentioned, there's an option to physically come and sit with someone, but there's people who maybe do not want to come because they are far away, or they don't want to be seen in the clinic because it's an open space. So it also provides that space for someone to open up because they're not being seen by the people in their community, and no one knows that they're seeking for help. So in that way, I think it certainly helps to break down that stigma and that barrier that's often associated with seeking for mental health support, especially in my country. So I would advocate for it, or at least try it out. And if the youth that you work with are interested in it, then it's definitely something that would be doable. And it's also easily accessible because it's done via WhatsApp, which is also low cost in internet cost or internet data usage, as we call it here. So more people can definitely access that through their phones. Everyone has a phone with WhatsApp, and you can call upon a counselor that you can talk to because they're usually available. Yep.
That's helpful. I think, especially for the younger, newer researchers in the room who are looking for research questions to examine, I think what can be accomplished in a virtual space and what maybe can't be, and which gaps we can fill with those are really interesting questions you're starting to work on. I'll ask one more question before opening it up to the audience. Like I just mentioned, Primrose and Florence, you can't see, but we have a lot of students in the room today who are interested in something related to this topic. We can only do so much. You're all working with a variety of populations on specific mental health problems. But when you're implementing these interventions, talking to people, Florence, when you're talking to your government policymaker counterparts, what would you say are the top priorities in adolescent mental health work now that you would like others to be considering when they decide what to focus on in this field? What would be your top adolescent mental health challenge that you don't work on yourself?
Well, if you allow me to go, I would say two things. One would be prevention of mental disorders and promotion of mental health for adolescents. I feel like other than the, like the mental health disorders like depression and the diagnosable ones and psychosis, I feel like adolescents struggle with a lot of mental health challenges. They need lots of skills on how to handle peer pressure. They need skills on how to handle things like bullying and challenges related to social media and relationships and those kinds of things, communicating, managing anger, building resilience. So I see that kind of life skills training in order to promote their mental health and prevent mental illnesses would be top priority for me. Um, in fact, I don't know if you know that we are doing a school mental health program as part of the MC's project. And that is so exciting to do. It's actually hard to catch kids in the healthcare system. If you think about MTRH where I work, the youth clinic we have is so HIV focused, but where do the rest of the youth go to? They get lost. Actually, in this hospital, which is the second largest in the country, there is no adolescent health clinic at all. So once kids are 14, they move out of the pediatric clinic and move to the adult side. So there's no dedicated outpatient service for them. So we saw it important to integrate mental health care within the schools, and we're offering life skills training within the schools. So I'd say we need general life skills training, but also mental health services that are dedicated to young people, I think, because their needs are unique.
All right, so that's important.
I mean, I feel similar. We and Maeve helped us do this. We now, part of SYV, we wanted to have a youth community advisory board at each of the sites. And through TIA HISA, it's an Adolescent Implementation Science Alliance. It's really HIV focused, but it's allowed us to do, I think Florence's point about government engagement is critical. I had a Fogarty fellow, Judith Beauchase. She's a psychiatrist in Tanzania, and she adapted SYV for schools. And working within the school system, I think, is so critical, and prevention is huge. And that's part of what we hope SYV does as well. But working in the school system, I think, is the same sort of red tape, a lot of bureaucracy, but everything you've said about Kenya has been my experience in Tanzania as well, that adolescents just get lost unless they have a specific disease, primarily HIV. So schools is a great way to find them. And the only thing I would add to what's been said, and I don't, it's not directly mental health, but we asked the youth cabs to tell us what the #1 challenges that youth face in their communities. And not surprising, #1 was unemployment. And we know, like, there's so many interactions, right? Unemployment, substance abuse was at the top of the list, and gender-based violence was very high at the top of the list. So I guess just thinking holistically and preventative measures, I completely agree with life skills and just sort of awareness. I think if you talk about mental health, you think of, the crazy person on the street. They don't really think of it as a spectrum that we're all kind of sliding on. And so I think just raising awareness would be a huge one. And I think schools is the right way to do that. And working with government and, the school system and getting buy-in, all the things Florence has already said, I totally agree. But if you talk to youth, they won't exactly answer your question. Like I'm dodging it a little bit, but there's a lot of issues that they see that lead straight into why someone might be depressed or not be doing great. So I think there's a lot of things that, a lot of gaps.
Absolutely. Absolutely. I would like to make sure we have some time for audience questions. Let's start with any in the room that we have.
Yeah, I have a question. I think I'm gonna address it to Dr. Dorothy-Doe. I feel your intervention is mainly, I would say, might be stigmatized in lots of ways because it deals with both with HIV and mental health, which are like highly stigmatized, at least in Africa. And so, considering that you mainly work with like only youth that are affected by either both mental health and HIV. I don't know if you also try and like focus on just the family, because I also feel like some participants might really go back to their homes, and you know they might not have maybe a very good environment, you know, and might relapse, and you know it's like a cycle. So I don't know if the intervention also has that aspect to try and like involve the family or whoever they're staying with.
Yeah, thanks. It's a great question. And the answer is yes, but you can answer the family based interventions better than I can. We do have caregivers as a component, and it's really important. So it's important from a just practical standpoint that youth have a lot of competing priorities, including home chores and things they need to do with the family. And so if the caregivers don't know where they're going or why they're going, or don't think it's important, they're gonna sort of not let the youth come. So for a logistics reason, it's important that the family is engaged. And so in SYV, we have, before we even start, and this was an adaptation we made from the pilot to the trial, that there's a home visit. So the peer leader goes to the house with sort of these are the sessions we're going to talk about, and we talk about condom demonstration, and we always make sure that parents know that, because we don't want people to feel like we're teaching their youth things they don't agree with. But we bring the family in, and that home visit is really revealing of just what is the environment that this youth is, you know, growing up in. This social determinants are all over mental, you know, all this stuff is just very interwoven. And so we, you know, they'll come, and the peer leaders write fidelity and session notes. So they'll say, you know, what the environment looks like. And if the environment is really concerning, like one, they said they're in a mud hut, it's rainy season, I'm really worried their house is gonna wash away. So then we use our referral pathway of, you know, who can help in the community. So back to community partners, and this, you know, it's a team effort on these interventions. But then we ask caregivers to come. So they come to the first session, and the caregivers enjoy meeting each other because they sort of have their own challenges raising a youth who lives with HIV. And they start to have sort of a better understanding of just what might this youth be going through. And then in session 6, when they're sort of face to face, and many of the caregivers are not the biologic parents, their parents have died. So now they're with the aunt or the uncle, and sort of this kid was forced to live with them. And sometimes there's a lot of dynamics and a lot of stigma. And then when they sit there and they hear the youth say, you know, I came to live with you because my mom died. And that's when I found out I have HIV. And I wasn't allowed to eat on the same plate as my cousin. And, you know, I felt really different. And it really like, wow, they start talking. It's really impressive. And I think that's really important. So the family and bringing the caregivers in, I think it's a critical component of SYV, and we do it different, but still engage family in Impact 2016. So I appreciate that question. I think it's important.
Have one online, maybe.
We do. We have a question from Chris Fire. So he also says, greetings, everyone, and thank you for your time. But he's talking about other mental health interventions for adolescents, maybe potentially with other diagnoses such as diabetes. So thinking about mental health that could improve other health outcomes. So if folks know of other potential interventions that do similar mechanistic work.
From Rose or Florence, I wonder if you have thoughts on that from being in some of the primary care and tertiary care clinics.
Yeah, so most of the ones that we've worked on, focusing on depression, and also depression in young people who have HIV. So perhaps Florence might have a quick answer?
Well, actually, I haven't had to implement any mental health interventions for young people with other chronic diseases, but it does make a lot of sense. I feel like for our setting, the opportunity isn't quite there. Remember what we said about having dedicated youth HIV services, but then for diabetes, it's really everyone. It's the adults and the young people, and so it's a bit tough to integrate that kind of youth mental health care into the general healthcare system. But I do see how important it is. And a couple of mental health interventions can be implemented for youth with chronic diseases. I'm thinking about stuff that helps with coping, with building resilience, with medication adherence. That would definitely be useful.
Thank you, Florence. And I know we have one of our master students working on peer-delivered diabetes education in India, which is exciting. So I would love to have conversations even when I visit Kenya this summer, Florence, and we're starting to work with kids, families of kids who have sickle cell disease. But many of those lessons or many of those project ideas are from the work that you all have been doing in the HIV space with adolescents and their families who are living with HIV. And so I appreciate that question, because I think that's where a lot of our attention has been. And now we can take those lessons to other illness populations as well, which is exciting. I want to wrap up here. I think we have contact information for our panelists. I think we could stay for hours and have fruitful discussion with them, but I would just like to thank them all for being here, and thank you all again for eating lunch.
Like in Kenya and Zimbabwe, I feel you. I'm happy to be here at noon, but those late night Zoom calls are not fun. So thank you.
Yeah, good night. Good night.